Hello, my name is Stephen Bader, and I'm an anesthesiologist at Heritage Valley Health System in Beaver, Pennsylvania. In this webinar, I will discuss the role antithrombin plays in regulating the coagulation cascade, the clinical implications of antithrombin deficiency, and the available treatment options for achieving antithrombin repletion. Antithrombin is an essential glycoprotein in the regulation of coagulation. In fact, approximately 80% of the normal physiologic anticoagulant effect against thrombin is dependent on antithrombin. Reduced levels of functional antithrombin impair the normal inhibition of the coagulation cascade, leading to an increased risk for venous thromboembolism. Reduced levels of antithrombin may arise from a hereditary deficiency or may be acquired secondary to a range of conditions. Hereditary antithrombin deficiency is caused by a gene mutation and can be distinguished as either type 1 or type 2. Type 1 occurs when the protein is normal, but not enough is produced. Type 2 occurs when the antithrombin protein concentration is normal, but its function is abnormal. The true prevalence of hereditary antithrombin deficiency is difficult to determine given its heterogeneous presentation. Therefore, the condition is often underdiagnosed. Prevalence estimates of hereditary antithrombin deficiency range from 1 in 500 to 1 in 5,000 people in the general population. Acquired antithrombin deficiency can occur secondary to conditions such as liver dysfunction and nephrotic syndrome, or due to depletion of antithrombin secondary to heparin use during major surgery or cardiopulmonary bypass. The primary action of antithrombin is the inhibition of activated coagulation factor 2A, also known as thrombin, and activated factor 10A. Antithrombin also exerts its effects, albeit to a lesser extent, by inactivating factors 9A, 11A, and 12A. By binding to factor 10A, antithrombin prevents the conversion of prothrombin to its active form, thrombin. Inhibition of thrombin prevents the conversion of fibrinogen to fibrin and decreases platelet and endothelial cell activation, thus inhibiting clot formation. As you can see here, procoagulation factors bind to antithrombin. Once bound, procoagulation factors are cleared, preventing the expansion of existing clots and the formation of new ones. Although antithrombin alone exerts inhibitory activity, in the presence of heparin, its anticoagulation effect is accelerated by at least 1,000-fold. The binding of heparin to antithrombin induces a conformational change in antithrombin, which accelerates the inhibition of factor 10A. In addition, as you can see here, the inhibition of thrombin requires heparin to bind to both antithrombin and thrombin to form a tertiary bridging complex, so thrombin's procoagulant effects can be inhibited. Heparin's anticoagulant mechanism of action is entirely reliant on the presence of antithrombin. Therefore, in the absence or near absence of antithrombin, heparin is ineffective. Because hereditary antithrombin deficiency is often underdiagnosed and acquired antithrombin deficiency may only become apparent in high acuity situations, heparin resistance may be the first indicator of antithrombin deficiency. A deficiency in antithrombin levels is associated with an increased risk for unprovoked venous thromboembolism. This figure presents the results from a case control study of 1,401 patients with a first objectively documented venous thromboembolism and 1,847 healthy controls. Investigators assessed the risk for venous thromboembolism associated with varying plasma levels of antithrombin, protein C, and protein S. The data shows that the adjusted odds ratio for venous thromboembolism risk is increased with decreasing antithrombin levels. Even modest decreases in antithrombin levels significantly increase the risk for unprovoked venous thromboembolism. In fact, other research has found that antithrombin levels of 80% or lower put patients at a higher risk for thrombotic episodes, and that patients with hereditary antithrombin deficiency are about 20 times more likely to have a venous thromboembolism compared with the general population. Up to 85% of patients with hereditary antithrombin deficiency will have at least one thrombotic episode by age 50, with almost 70% of these patients having a thrombotic event before the age of 35. Therefore, proper management of antithrombin deficiency is essential for reducing the risk for venous thrombosis in these patients. Long-term anticoagulation is generally not used for patients with a confirmed diagnosis of antithrombin deficiency who are asymptomatic. Instead, asymptomatic patients are advised to mitigate the risk for thrombosis by avoiding medications associated with an increased risk for thrombosis and maintaining mobility, a healthy weight, and adequate hydration. When pharmacologic management of patients with hereditary antithrombin deficiency is warranted, treatment should be individualized and generally falls into three domains: treatment of acute thrombosis, long-term anticoagulant thromboprophylaxis in symptomatic patients, and short-term prophylaxis in high-risk clinical settings. For management of acute thrombosis, treatment options include heparin or low molecular weight heparin. Anticoagulation with heparin is dependent upon antithrombin to exert its effects, so special care is required for use of heparin-based products in patients with antithrombin deficiency. Higher heparin doses may be needed to achieve therapeutic anticoagulation in these patients. However, administration of excessive doses may result in bleeding or other complications. In this scenario, patients may require antithrombin replacement in the form of concentrated antithrombin or fresh frozen plasma. Other treatments include direct thrombin inhibitors. For example, bivalirudin is indicated for anticoagulation in patients undergoing a percutaneous coronary intervention, including those with heparin-induced thrombocytopenia or heparin-induced thrombocytopenia and thrombosis syndrome. Use of bivalirudin, however, is limited by the lack of a reversal agent, or antidote, and its high cost. Both warfarin and direct oral anticoagulants are safe and effective treatment options for symptomatic patients who need long-term anticoagulation. The use of warfarin requires frequent monitoring and potential lifestyle changes to accommodate dietary restrictions, so some patients prefer to use direct-acting oral anticoagulants. Short-term thromboprophylaxis is also recommended for asymptomatic patients in high-risk clinical situations. Clotting risks are increased in both surgical patients and during pregnancy. The FDA has approved antithrombin concentrate for the prevention of perioperative and peripartum thrombosis in patients with hereditary antithrombin deficiency. Antithrombin concentrate and fresh frozen plasma are commonly used for the replacement of antithrombin. Antithrombin concentrate is indicated for patients with hereditary antithrombin deficiency for treatment and prevention of thromboembolism and for prevention of perioperative and peripartum thromboembolism. It is supplied in single-use 10 ml vials and after reconstitution with 10 ml of sterile water for injection at a concentration of 50 IUs per ml of antithrombin concentrate. Antithrombin concentrate can be stored at room temperature for up to 36 months and is administered as an IV bolus infusion. Fresh frozen plasma is indicated for the management of patients with selected coagulation factor deficiencies, congenital or acquired, for which no specific coagulation concentrates are available. Fresh frozen plasma is supplied in larger volume bags, such as 200 to 250 ml bags, at a concentration of approximately 1 IU per ml of antithrombin. Fresh frozen plasma needs to be thawed before use and is administered as an IV infusion. The product must be stored at -18 degrees Celsius or colder and must be immediately infused after thawing or stored at 1 degree Celsius to 6 degrees Celsius. The distinctions between antithrombin concentrate and fresh frozen plasma denote clinical implications that are important for clinicians to consider when selecting the most appropriate product for antithrombin replacement. First, fresh frozen plasma contains antithrombin plus other plasma components in varying levels. Antithrombin concentrate provides predictable amounts of antithrombin with a predictable half-life. In addition, antithrombin concentrate directly replaces antithrombin, making it an effective choice during high-risk events. The loading dose volume for antithrombin concentrate is calculated with a clear formula, so each dose is precise and accurate. Antithrombin concentrate delivers 50 times more antithrombin than the same amount of fresh frozen plasma, as a concentrate isolated from other proteins and factors. The amount of antithrombin in a 10 ml vial of antithrombin concentrate equals the IU of antithrombin in 500 ml of fresh frozen plasma. Patients administered fresh frozen plasma receive a higher infusion volume and are at an increased risk for volume overload. Risks associated with fresh frozen plasma include allergic reactions, transfusion-related acute lung injury, transfusion-associated circulatory overload, the possibility for infection transmission, and febrile reactions. Antithrombin concentrate, on the other hand, has no known contraindications and a low risk for major bleeding complications, even in the presence of heparin. Antithrombin concentrate results in few adverse effects, a 50-fold decrease in transfusion volume, and the manufacturing process contains steps to reduce the potential for infectious disease transmission. Fresh frozen plasma is associated with more waste and delayed care due to transport times to the operating room and the thawing process. Thawing alone takes at least 20 minutes. Then another 8 minutes to achieve the therapeutic activated clotting time. The aggregate cost of these delays becomes significant, considering the average operating room cost of $46 per minute. In contrast, time and labor costs associated with antithrombin concentrate administration are negligible because the vials can be stored at the point of care at room temperature. In summary, antithrombin plays a critical role in the regulation of coagulation. Most of the normal physiologic anticoagulant effect against thrombin is dependent on antithrombin. Patients with hereditary antithrombin deficiency are at an increased risk for venous thrombotic episodes, and because this condition is underdiagnosed, heparin resistance in high-risk situations may be the first clinical sign of antithrombin deficiency. Antithrombin repletion is often achieved with antithrombin concentrate or fresh frozen plasma. Overall, antithrombin concentrate is a cost-effective and timely option. Thank you for listening.